Thank you very much, Jarkko, and good morning, everyone. It is my great pleasure to report our safety and interim analysis of a randomized clinical trial in patients with adolescent idiopathic scoliosis. Our disclosures are reported here. So, the aim of surgical treatment for AIS is obviously to correct the deformity and to prevent further progression and deterioration in pulmonary function. Pedicle screw instrumentation provides more than 65% of the coronal curve correction and represents the golden standard surgical treatment. However, it's quite difficult to restore the thoracic kyphosis in patients with thoracic AIS. And it remains still unclear if we can improve both the coronal and sagittal curve correction using apical Ponte osteotomies in patients undergoing segmental pedicle screw instrumentation. Therefore, the aim of this study was to evaluate the impact of Ponte osteotomies for thoracic AIS using segmental pedicle screw instrumentation. We hypothesized that apical Ponte osteotomies would improve coronal and sagittal curve correction as compared with the no Ponte group in these patients. So this study represents a Finnish multicenter randomized clinical trial. The intervention is apical Ponte osteotomies, minimum 2, maximum 4, as compared to standard bilateral facetectomies. And we included patients with lengthy 1 to 4 curves, more than 45 degrees, aged between 10 and 21 years. Exclusion criteria: not willing to consent. Other approaches: thoracoplasty, VCR, or abnormalities in MR images or blood coagulation. And you can see the picture from Alberto Ponte on his description of the technique. So out of 110 cases, we identified 80 with lengthy 1 to 4 curves, and of them 52 consented to this study. 26 received standard treatment and 26 received Ponte osteotomies apically, and all these patients were included in this safety and interim analysis post-operatively. We collected the typical clinical characteristics, intraoperative variables. Radiographic parameters of interest were major curve pre and post, thoracic kyphosis between T5 and T12, complications such as neurologic deficits, deep surgical site infection, and need for blood transfusion. And the primary outcome for this safety evaluation is, of course, the complication data, and the primary outcomes at year follow-up will be major curve correction, thoracic kyphosis restoration, and forced vital capacity at year follow-up. So the groups were very similar. We fused a little bit more than 11 vertebrae. We aimed at screw density 2.0, and the patients in the Ponte group received 2.8 Ponte osteotomies, and obviously no Ponte osteotomies in the no group. The blood loss was around 650 in the no Ponte and 665 in the Ponte group, obviously no difference. Surgical times was 9 minutes longer in the Ponte group, again not a clinically or statistically significant difference. And when looking at the coronal curves, we started from typical a little bit above 50 degree curves and then corrected these to a little bit less than 20 degrees. There was no difference in terms of curve correction for major curve or proximal thoracic curve or lumbar curve in the study groups. However, when we looked into the sagittal balance, we can see that in the Ponte osteotomy group we were able to increase the kyphosis by 7 degrees, while there was no change in the no Ponte group. and this was statistically significant difference for the change in thoracic kyphosis. Additionally, if we wanted to stratify these patients into normal thoracic kyphosis between 20 and 40 degree post-op, only 23% in the no Ponte, but more than 50% in the Ponte group regained athoracic kyphosis to this normal area. So limitations, the strength is obviously a randomized clinical trial. This is a safety evaluation that we don't have more complications or no more blood loss or other infections. At this point, we still have a limited number of patients. It's an ongoing study, and we only report at this stage the early outcomes. In conclusion, apical Ponte osteotomies are safe, and they do not add significantly to complications, blood loss, or increased OR time. Additionally, Ponte osteotomies do not increase major curve correction in the coronal plane. While thoracic kyphosis restoration is more effective, normal kyphosis was reached much more often in the Ponte group than in the no group. Effects on health-related quality of life and pulmonary function obviously remain unclear. Thank you very much for listening.